G'day, and welcome to the AHDC podcast series, Health Design on the Go. I'm your host, David Cummins, and today we're speaking to Paul Lambert, who is an experienced healthcare leader with over 25 years' experience in the healthcare sector in Australia and the UK. With extensive skills in leadership, negotiation, and strategic planning, developed in major infrastructure and operational roles in private and public sectors, Paul has joined the team at Think Human in 2022 to build a strong customer focus. Paul is a builder and collaborator who delivers high-quality outcomes in digital health, co-design, and health leadership. Today, we look forward to talking to Paul as part of our Innovation and Technology series. Welcome, Paul. Thank you for your time to be here.
Thanks, David. Lovely to be here.
So a lot of people don't actually understand the word digital health, and especially when it does come to consumers, because a lot of people in the consumer world with digital health is, certainly in my experience, angry builders or project managers or directors bring in the IT team saying, it doesn't work, fix it, we can't operate. What is your world of digital health when it comes to consumer experience?
Yeah, thanks, Dave. Look, I think the conflation of ICT and the technology with digital health is really part of the problem, part of the challenge we have in terms of trying to give people a more comprehensive idea of how technology and the human experience comes together in healthcare settings to deliver better outcomes. And if I was thinking about digital health is a series of outcomes that we're trying to achieve as opposed to a series of technologies that we bring to problems which may or may not exist. So digital health in and of itself tries to focus not so much on what the technology is, what the solution might be, but actually what outcomes we're trying to achieve, whether that's for health consumers, whether that's for health staff, clinicians or other staff, or combinations of those, with a real strong focus on understanding that problem that we're trying to solve.
So how does Think Human go about that consumer feedback loop to make sure that the digital health footprint and requirements are set up for existing or new project?
Yeah, I think what we try and do is really start with the problem. The number of situations that we're brought into where there's a ready-made solution or a poor conceptualization of the problem that we're trying to solve is really common. And we spend a lot of time actually talking to clients about actually what is the problem you're trying to solve and how do you know that's a problem? Is it a problem because there's a myth and a legend about it? Is it something that you've heard? Is it something that somebody next door has an issue with? And actually getting people to go through that rigorous process of asking, well, what is the problem you're trying to solve? How do you know it's a problem? And who's it a problem for? Talk to your stakeholders, talk to your end users, talk to your customers, your consumers, however you want to describe those people. Start with the problem and then design the solution hand in hand then with those consumers, the people that are ultimately going to use that product. You'll save yourself time in the long run in terms of change management and education, and you'll actually end up with a much greater chance of having a solution which is going to work long term.
Yeah, I always say, especially thanks to design thinking, 90% problem, 10% solution. A lot of people are afraid to sit in the problem, and a lot of people go into solution focus, but we've all got examples of that solution. Sometimes it works, but majority of the time it needs improvement, and certainly there are examples where it doesn't work at all. So why do you think people are afraid to sit in the problem so much? Is it time? Is it money? Is it ego? Is it experience? Why are people so afraid to sit in the problem and actually understand the ultimate question that needs to be answered?
I think that's a great question. For me, in my experience in healthcare, both being a busy executive for 20 years before hopping off that bus and then working with busy clinicians, it's really the headspace to think clearly about what it is that they want to do. And I think if you provide them with that space to think, to create ideas, to put up crazy proposals, then actually they work their way through that problem extremely well. Smart people, they know their context, they know what they have to do. I think within healthcare, though, there is a little bit of a clash sometimes between the philosophy behind design thinking, which is just start, ideate, think about the problem, fail quickly, fail fast, with this notion of a medical model which comes up with a hypothesis and tests that hypothesis over time. It can tend to discourage that fail fast kind of notion that we rely on in terms of design thinking and designing a whole lot of very rapid solutions on the chance that and on the knowledge that at the end of that process we will come up with the right fit. So I think there's a little bit of a clash of cultures there as well, for people to leave their problem-solving philosophy at the door, come in and follow the process through with much more of a design focus.
Yeah, and especially a clash of priorities as well, because certainly in the construction industry itself, there's a lot of people who literally think fast. You have to problem solve all the time. There is literally on site or where they're doing the planning, there is minimal time to plan in some situations. However, I always say 90% planning, 10% execution. I do feel that there is opportunity in that planning phase, if not the business case phase, to make sure there is that extra effort to understand the problem. What are we solving for? A lot of people push for the business case for the government or for whatever it may be to try and make sure they're giving a solution and throwing a dart on a board without actually understanding the problem, which in my experience can result in wasted money, wasted time, poor quality outcomes, and not exactly the best patient experiences as well.
Yeah, I'd agree with that. And I think if you then look at industries like healthcare, where you're not necessarily dealing with the creation of physical artifacts and buildings, you're actually looking at the creation of systems, processes, people interacting together under a high pressure environment where actually you get it wrong, people do die, then that essentially creates the tendency to rush for a solution, the requirement to be the wise person with the solution. I've been here forever. I know what the solution is. We can solve ambulance ramping if we only do blah, if we only put up a new screen, if we segment this room into different parts, if we just add a new CT scanner. Whereas actually you take that time, your 90%, to actually understand the true nature of the problem, the mess that people create, because we are messy. Dealing with humans is a messy process, but actually sitting in that problem, sitting in that mess, and actually providing people with some tools and a process to work through that, then, it's the classic notion that order becomes an emergent property and emerges from these slightly chaotic systems.
I know you've done a lot of work in Adelaide, obviously, and you do a lot of work in the digital health space. How does one solve the problem for solving problems for digital health, especially considering by the time it's actually implemented, a lot of that technology is considered out of date? So how does one go through that process, not only to plan, but to future plan and future proof digital technology?
Yeah, I think that's true if you're looking at the solutions. The solutions are often out of date or not up to date at time of opening a facility that might take 10 years from conception to delivery. But the issues and the problems, back to our point prior, the problems are largely the same. The problems of demand, the problems of flow through hospital, the problems of delivering best quality care for a fixed cost, they are problems which were with us 50 years ago in healthcare and will be with us in 50 years' time. The trick is to have really clear problem definition up front in those projects such that you understand what you're solving for, and then you delay and you delay and delay as much as you can before you actually have to pick a solution which matches the requirements, functional and otherwise, of the people that have to use that system in the long run. So I think there are ways in which you spend time understanding the problems and designing a broad set of outcomes that you need to deliver, but you hold off then on either procurement, delivery, and installation of that until you can't hold off any longer. And even then, as you would know, it is potentially a 3 or 4 year delay anyway. But again, using principles around interoperability, designing for known redundancy in the future such that you can switch elements in and out, as opposed to committing to large black box solutions where you're going to be locked in for 10 or 20 or 30 years, I think are some of the ways in which I've seen current hospital projects trying to adapt and adjust to exactly that planned redundancy that you talked about.
Yeah, it's really interesting. In the world of AI, I know you're pretty much a leader at the moment in the world of AI. Do you mind just telling people what health AI is?
I think any artificial intelligence at the minute is an extremely catchy kind of idea. I think that most people confuse what we see as large language models, so very clever semantic models, talking about solutions and skimming language, if you like, as AI. They produce some amazing results, and with the right kind of training, they can be hugely effective and adjuncts to particularly people's productivity. I think the kind of AI that I'm interested in and working with in the startup that I'm working with really is trying to focus on taking large, complex data sets and actually turning them into actionable insights. Again, a slightly kind of hackneyed term, but really, if we want to progress healthcare, we need to provide clinical staff with access to this massive and ever-growing body of clinical data, which is theirs, which they've helped to generate, and actually help refine that into a format which delivers clinical insights and gives them a nudge in the right direction to make the best decision that they can. The distinction between art and science within medical professions and healthcare is one which is often talked about, where actually the art that they talk about is a whole bunch of internalized experience over a huge amount of time. Imagine if we can actually harness the power of a single medical record here in South Australia and actually take a huge amount of data, put it through some very smart algorithms, work with people who understand the context of that data so they know what it relates to, and then integrate that into people's workflow so it's actually there and it can deliver clinical decision support. Now, what that means is software acting as a medical device. It means a whole bunch of implications for regulation, as it should do. And that is a long journey and a long path. So talking to different people about different types of artificial intelligence, if you like, there are different kinds of understandings about what that should be. For me, it's how we harness big data with smart algorithms, with good technology, all in context and in workflow for the clinicians that we're trying to deliver solutions for.
So can you give me an example of that? Like in my head, what you're talking about is the Star Trek doctor, which basically you speak to a hologram and say, Doc, I've got a sore arm. And he pulls out a little thing and he says, you've got a hairline fracture. Is that the type of thing you're talking about where people are actually speaking to a computer screen or a mobile phone with their symptoms and a possible solution might be there?
Yeah. I think that would be progress from what we have at the moment, which certainly is a whole lot of medical professionals sitting behind a workstation on wheels, staring at a computer when they should actually be looking at the patient and having that conversation directly with the patient. Whether we get to holograms and that kind of user interface, but you can definitely see how the large language models that we're starting to get used to, whether it's Siri or whether it's Copilot or ChatGPT, start to be the front end for the kind of decision support analytics that I'm talking about. And you're actually having a conversation with the computer about what are they seeing? What's the computer seeing and identifying in this patient? How does it relate to the 1,000 patients that you've seen like this in the past? And what might you want to think about to make sure that you're not missing things, or how you're actually correlating and joining the dots between various different clinical parameters. Now, in the first instance, that'll look very similar to the kind of, whether it's a dashboard-led system or some other kind of user interface that we have now. But eventually, I think screens will be a thing of the past. I think keyboards and mice will be a thing of the past, and we'll be much better at interacting with these systems through verbal prompts and even running in the background, pushing up information which we may not have seen otherwise.
Yeah, that's interesting. And I must admit, my knowledge on AI is growing, but I don't know enough about it yet. With health AI, does that mean it is limited to Australian data by one source of person inputting that data? Or does that mean it's a global network of data where a hospital in America might be inputting some form of data which we can leverage off and benefit from?
Certainly the work that we're doing at the moment is really governed by the sovereign data requirements, and the patient identifiable data that we use in healthcare is obviously highly regulated, and that's how it should be. And so all the data that we use is stored within Australia, and more so than that, within highly secure health networks to provide the absolute assurance to the public around their health data, I think is paramount. The industry will very rapidly lose public trust and public license if it can't demonstrate that it can adequately look out for and look after the healthcare data that people have in the ecosystem. Having said that, regulation needs to ensure that it's not so tight that healthcare data is not able to be used by beneficent either researchers or companies to generate positive health outcomes across a population. So it is a really fine line. And I think at the moment what you'll see is a correction of to one direction, which will be very focused on protection of data. And then we'll need to swing back to a midpoint, which allows a certain set of data for certain reasons under certain circumstances to be used and aggregated as part of advanced analytic systems or artificial intelligence.
Yeah, and just thinking of the possibilities, even from a demographic point of view, from a urban planning point of view, from a medication point of view, from a future growth point of view, the actual possibilities are endless, which, if I'm thinking out loud, will probably take away a significant amount of jobs at some point in time, because the data should actually be there through speaking to a health AI what's the prediction of elderly residents in X zone and therefore future proofing for that area. So it sounds phenomenal.
I would describe it as taking away some of the bullshit jobs, Dave. I'm all for people doing people jobs, but I'm also all for software to do software jobs. And the things that software does really well increasingly is to take huge data sets and actually start to draw some correlations across and between those with some really strong algorithms sitting over the top that learn over time. But importantly, and this is so important in healthcare, if you don't understand the context from which the data comes from and in which it's being used, then actually you're going to have a really smart machine that's spitting out nonsense that nobody understands what to do with. So that human element, again, the requirement to develop these systems in partnership with clinicians, in partnership with the community, whose data it is obviously, is really important because it creates the context for understanding what that's telling you, and it maintains that social license that allows you to use those data for the improvement of, yes, my health, but also at a population health level to actually start to improve the population of all of us by aggregating these big data sets together and learning what they're telling us. But again, at the moment, this kind of AI that I'm talking about is big data and fancy maths. It's not magic. And it's being enabled by the increase in storage and the increase in computing power that we're now able to get access to at a reasonable price through cloud-based technologies.
Yeah, it's absolutely phenomenal. Just the mind is boggling right now with what you are saying. So keeping everything you've just said in mind, what do you see as the future of AI in the next 5 to 10 years? Is the hologram from Star Trek realistic? Or is that still too science fiction?
No, I think there will be a version of that will be available. The question will it be a generalized AI which can act across a number of different domains, or will we continue to develop a whole range of very, very narrow and deep systems which serve specific purposes? I think you'll see convergence. You'll see the proliferation of narrow and deep systems over the next 5 years, and then the 5 years following that, you'll see the convergence of those into kind of meta and mega structures which allow us to get greater and greater generalizability. The trick then is to make sure that we understand what we're being told, we understand the relationship of the decision support and the data back to the individual from which it's taken, and that is a human role. That's a human job to understand that interaction between the clinician and the patient, and then to understand how that data is aggregated through what systems to ultimately then be an input into these larger systems.
And keeping in mind your world of digital health, especially with consumer feedback, especially with new and retrofitting buildings, and I just don't know the answer, hence the question, does that mean less infrastructure will be required?
It's a very, very topical area at the minute. I think if you'd asked me 5 years ago, I think the possibility and the options of virtual healthcare were being touted as very strong alternatives to building hospital beds and building new infrastructure. I think the evidence that's starting to come out now through good research is actually showing that virtual care is often an adjunct to rather than an alternative to traditional bricks and mortar. And so I think we're a significant way away from, virtual healthcare putting large hospital designers and builders out of business. So I think you're probably safe there, I think, Dave.
It was a personal question, so thank you for that.
But consider how traditional three-dimensional walkthroughs of buildings used in design, whether that's BIM models or others, roll up into true digital twins, and how a digital twin of a facility then comes together with some of these advanced AI systems that I'm talking about, such that you end up with a virtual hospital that can run in real time, in parallel to your current hospital, and allow you to do things that you could never do in an operational hospital. What happens if we double the size of our ED? What happens if we triple our ambulance arrivals? What happens if we actually move this whole cohort of patients out the back door? What does that do to our flow? The idea of evolving the digital twin away from just a design construction notion into a real life, real time simulation of what we're seeing from, yes, a physical, but from also a clinical point of view is a really exciting prospect, and something which I think is probably within our reach now, technically. But it would take the time to understand the context. It would take money then to be able to create the grunt, to be able to create those systems. But each individual element exists at the moment. So I think that's a lovely thing to aspire to, is a full-blown digital twin of your hospital running in parallel to allow you to understand what it would take to make it the most efficient and the safest hospital available.
I know there's quite a few Archie students that listen to this podcast, so I have no doubt that many of them would be inspired by what you just said towards that end. And I think it is the way to move forward. I think the new models of care should be changing for the future, because even if you had a bed for every patient in the future, it's not going to work. So I think we do have to put our thinking caps on and really change and pivot to how our models of care and treatment is provided to patients. And I just think what you've said, and leaders like you, especially in this AI space, is so important, because AI is the way of the future, like it or not. And if you do not get on the bandwagon early, you'll be left behind. And even though there will always be, in my opinion, room for nurses and doctors and patient care and human touch, AI has the ability to actually future proof us in the long term, whether it's digital doctors or digital hospitals or whatever it may be. And I think it's people like you, Paul, who are on the forefront of this that will be world leaders in this space. And I really look forward to speaking to you again in the future to find out more about what's been happening in health AI and what you've been up to in the future.
Thanks, Dave. It's moving really quickly. It's really exciting, and we need to make sure that we keep the patient at the centre of everything we do.
You have been listening to the Australian Health Design Council podcast series, Health Design on the Go. If you'd like to learn more about the AHDC, please connect with us on our website or LinkedIn. Thank you for listening.